So I'm gonna make this topic simple for you. Who can get PCOS? How is PCOS diagnosed? So then we have Rotterdam. It talks about polycystic ovarian morphology. So ultrasound has been added here. Choice of ovulation induction. How do we treat gonadotropins? Do we treat them, which is the commonest also? But for us, all the girls and boys who are present here, for us, most important here is ovulation induction. To read a recommendation, there are 4 ways I've told you already. Recommendation for medical outcomes and aligning with the recommendations for the general public. And after the pregnancy, also of GLUT4 glucose transporters. So this is the way metformin acts, and there are multiple diagrams and images you can see at the Google as per the guidelines. But they have put an asterisk here. They say clomiphene resistance and no other infertility factors to improve. So they say we can use letrozole or clomiphene, or we can use it directly also. And in case you use it directly, you can combine it with metformin. So EBR says that evidence-based recommendation says that gonadotropins with addition of metformin, achievable, realistic, timely. That's not only about PCOS. Whatever we do in our lives should be smart. So this is what we teach you in total quality management. Grade, I hope you remember what grade is. Then second term is SMART. Specific, measurable, achievable, realistic, timely. That's not only about PCOS. Whatever we do in our lives should be smart. So this is what we teach you in total quality management classes also. So 10% of weight loss is good and it gives us a good outcome. So how do we lose weight? So we have to take food which has got less energy deficit of 30% or 500 to 750 kilocalories per day. खाने में 30% energy deficit create करना होता है to lose weight. This you have to remember. Try to lose 10% of body weight, and no specific dietary type or methodology is recommended. You can just want to lose weight, and that is more important. Then coming to beautiful guidelines, look at this. These are the guidelines categories. This is a category. So they say that, okay, this is to be done. Must, you should do it. And losing around 500-600 calories per day is the right thing to do. So use of orlistat. Orlistat recommendations are should be considered as an experimental therapy. So giving to a PCO patient orlistat is an experimental pathology, experimental technology or therapy is what I'm going to tell you. And then coming to the exercise intervention, I've already covered. Now there are 2 categories of people. One, we have to prevent their weight gain and maintenance of health. One is prevention. The other category of people is that we have to go in for moderate weight loss and prevention of weight regain. There are 2 different categories of people. So when we want to prevent the weight gain, then we have to go in for minimum of 150 minutes per week of activity of moderate, and then moderate intensity physical activity of 75 minutes per week. So this is the type of physical activity, 150 minutes or 75 minutes per week. But in case we want to go in for weight loss and prevention of weight regain, then these numbers become double, as you can see here. I think you can just read these things. Read this chapter number 1 is very well covered here. So we have to prevent from the very beginning is 150 minutes per week or 75 minutes per week, and to actually lose it and not allowing body to regain it, it is double the amount. This is a way I normally remember it. Okay, good. Now this is what is written, and look at the categories here. So I think it's absolutely fine. That's the right way you can do it. Please read these recommendations 3.4.1. Chapter 3.4 is very, very important. Do read it after you get the book. Laparoscopic ovarian surgery is the how many holes we make in the ovary, what depth, what cautery, what current. This is important, and we all know about it. But it is a second line therapy. You shouldn't just go start and puncturing all the ovaries. That is not the right thing to have. Don't puncture, don't burn the ovaries. Just second line therapy, I feel. And from my side, I feel that we should not be doing it because it will lead to multiple problems. It can lead to multiple problems because it can lead to ovarian burnout, fall in the levels of AMH, and it will burn the follicle. So I don't actually recommend it. Uh, we have to know these all are the risk. These risks are quite a many. So please be careful. Don't do a thing because that can lead to complications. Avoid doing laparoscopic surgeries because they can lead to problems. And we are giving you the next, I think the resonance bulletin is on ovarian surgeries by laparoscopy for PCOS. Do read about them. So coming to 5.9 in vitro fertilization, we know that 5.9 means should we do IVF or not? When should we do an IVF in a patient? So IVF is to be avoided. IVF is not the method of choice, but in case we have failed IUIs, we can go in for an IVF. So it can be offered as third line therapy after the first and second line have failed. So IVF is no way the first line of therapy, is second or third line of therapy always. And the advantage of IVF is that we can always promise the woman a singleton pregnancy. This is very, very important thing for us. And we can control ovarian hyperstimulation very beautifully also. But not the first method of treatment. Now, which method to use? Should we use an antagonist protocol with cetrotide or should we use lupride? This we have to find out. So always remember that for any IVF cycle, we always use an antagonist protocol. Just remember that. Always antag in PCO. In fact, for everything we are using antag only now. We use antag and we never use HCG. So using an antag cycle and never using HCG, never is the key take-home message for all of you. Trigger. Which trigger to give to the patient? Trigger type is very clear. The trigger should always be with agonist. So it means that we are carrying out an antag cycle. This for everyone is a mantra. It's a beach mantra. It's an antag cycle and agonist trigger. This is what you have to remember. This will avoid all complications. Which FSH to use? So here they say in PCO patients, they prefer FSH over HMG. This is what I could make out from this. To try to do cycles more with the FSH because they already have high levels of LH in their body. But we don't have clear-cut guidelines over this. But I always feel that give them for 6 to 8 days, give them FSH. In the last 2 or 3 days, you can add HMG. This is the way I do it. And just remember that urinary or recombinant FSH, there is insufficient evidence to pick up the preparation. This we still don't know. But FSH is the drug of choice. What type, urinary, highly purified, or recombinant, I'm not very clear about this. Exogenous LH. Some people want to add LH from outside. Not to be given. They say that should not be routinely used. So LH is not recommended to be added. So this goes and tells us that as far as possible, do the cycle with FSH. Then should we add metformin? Metformin is a wonderful drug for IUI with clomiphene, BMI high, failed clomiphene, or only metformin induction we are doing. So metformin works pretty well. That's called adjunct metformin. Should we use or not? Let's see here. Here we find that metformin is recommended, may be used, could be used. As I told you, the should, could, should not. In case you remember, I used 3 terms for you. One was should, then was could, then should not. In case you were with me, these are the three recommendations. So could is the second recommendation here. We can use it. That's absolutely fine to improve CPR and reduce the risk of ovarian hyperstimulation. So metformin can be given. And how do we give metformin? A dose between 1 gram to 2.5 grams. I feel I'm happy with 1 gram of, otherwise people keep vomiting. And stop metformin at the time of pregnancy test or menses or otherwise indicated. So metformin we start, but in case it comes positive, normally I give metformin till around 8 weeks. Otherwise, metformin, I do it, but otherwise metformin can be stopped after the result has come positive, and there is no reason of her developing ovarian hyperstimulation. At any point, you can stop it. So metformin can be added in any protocol, and it is very good. It will avoid ovarian hyperstimulation. So metformin should be added as an adjunct. In vitro maturation is a lab topic, 5.9, chapter 5 and 0.9, 5.9 recommendation that IVM is a good method, but in IVM, we take out the follicles when they are small. Normally we do the pickup at 20 millimeter follicle size. In IVM, we do pick up at around 10 millimeter follicle size or even less or a bit more. So there is less chance of developing ovarian hyperstimulation. So in vitro maturation is a good method, but our country, the whole world is not ready for IVM because we get immature eggs, which may be GVs here, which may be GVs or which may be M1s, which we mature in the laboratory and take them to metaphase 2. Okay, I think I've ended my talk here. I have spoken for around 1 hour or 1 hour and 5 minutes. So the take home message is very clear. This chart again, algorithm 5, please go back and read from the booklet. Algorithm 5, that's very important for you guys, all of you guys and girls. First of all, we should carry out the non-pharmacological management. Always. Lifestyle has to be improved. Weight loss, exercise. 10% weight loss, I've told you, number 1. Number 2, prevent weight gain or lose weight and then stop regaining. How to do it, I've told you already. I've not told you. It's the guidelines. You can read it yourself. Then coming to the first line pharmacological management for infertility, letrozole, clomiphene plus metformin, metformin. Gonadotropins can also be used for first line, can also be used when we have ultrasound available with us and patient can afford. This is very, very important. Second line is pharmacological or surgical management. Here we give gonadotropins or we do laparoscopic surgery. This I'm not very fond of. So I will say don't do it. Third line is IVF. So this is the way we manage our cases. So thank you so much for being with me. We've got a beautiful booklet on antioxidant which has been sent to you now. Do read it. It's a lovely book. And as I'm moving ahead, we welcome you for the next curtain raiser. Our next curtain raiser is on thin endometrium. It's on thin endometrium. Please attend that curtain raiser. Then we have the curtain raiser on incubators the next Sunday. Then we have one on fertility preservation. So these 3 curtain raisers are here. I'm writing my number here for you again in case you have not saved. Save my number in case you want to attend these curtain raisers. And these are my numbers. Please save it. This is 83005. You can send us a WhatsApp message. This is one. And the coming curtain raiser, coming resonance salon is on laparoscopic drilling in PCOS. Should we do? Should we not do? And how to do will be the point here. And then we have got for you 2 coming curtain raisers, one on chlamydia and other is on thin endometrium. So we are somehow trying to, whatever we are teaching you, we are trying to take out a curtain raiser on those topics, and this thing can be given to people. So this is not, we don't record these curtain raiser. They are not recorded. They are not recorded. You can't get a copy of this. You'll have to attend these curtain raisers. And they'll be available in some time on our virtual university, where it will be posted for some time. But we are not, by no means we are doing any, we are not giving you the video recordings of this. So thin endometrium, and I think that's it. So I have.
Good morning, sir. Can I ask a query?
Give me one sec. Give me one sec. Just give me one sec. We'll take all the queries. Let me come to. Just let me come to.
I want to announce two things. First, about our scholarship program. Like we are planning for a scholarship program for course 1 and course 2, and we will choose 2 candidates for each course. So whoever want to apply for it, you can contact us anytime. And the second thing, the YouTube channel is available for all of you. The Matritva, and the second one is related to ART. So you can go through those channels, and you will definitely find them beneficial. And the SPY platforms, many people are asking about that in the chat box. Those SPY platform is basically accessible for our candidate who have joined the course. So this is all from my side. Now we can start. Sir, we can start question answer round.
Yeah, we'll take few queries. I can see 100 of them.
Yes,
sir. Good morning, sir.
Great. Great.
Good morning, sir.
Yes, good morning.
Yes, sir.
For some time we can put on our cameras.
Yes.
Is Neeti with us today? Neeti or Gunjan, are you with me?
Yes, sir. Good morning.
Hi Neeti. You let me fight the battle. Be with me.
Hello.
Dr. Neeti is our faculty, and she teaches with us. So when a lot of bigs come on me, Neeti can be my guard. Okay, guys, we can start.
Yes, sir. In PCO with ART, sir, when we start the stimulation or ovulation induction, that is after menstrual regularization or when the natural menses come?
Okay. Dr. Varman, how are you doing?
Fine, sir. Doing well, and I'm doing 𝐂𝐻𝐿, sir, and my oocytes are fertilized. We have good embryo also.
Oh, wonderful.
Thank you, sir.
I feel jealous looking at you. You're so chilled out. Delhi is very cold. Delhi is very cold. So see, the point was that you said that you. क्या बोला था आपने फिर से बोलेंगे एक बार मेरे को?
We have to do the menstrual regularization for
always.
induction.
In case you ask what I do, if certain things are given in the booklets, what I do, in case I get a patient with PCOS, how I handle that patient. They are normally anovulatory. I normally try to get 1 or 2 cycles in them. So what I do is, my favorite is Dine and Metformin. This is what I am doing.
Yeah.
Here, again, I'm saying this is what I am doing. I give them Dine plus Metformin for 1 or 2 months, make them bleed, let them get 1 or 2 cycles, and then from day 2, I start.
Okay.
We have to get withdrawal bleeding in them. Withdrawal bleeding is very important. And Dine and Metformin, Dine contains cyprotron acetate, so it's an anti-androgen, and Metformin as such will regularize her periods along with cyprotron acetate. So then after 2 months, then I start their case, because in women who are chronically anovulatory, otherwise you can give them Pramolate, 10 milligram BD for 5-7 days, they will get their periods, and then you can start again.
For how many months you will give the Dine?
Dine I give it for, depends upon how bad they are. I go to around 2 months. I like them to have minimum 2 periods before I start for in chronically anovulatory patients.
Okay, sir.
Or you can give Pramolate and get their periods, depending upon how you want to.
Yes, sir. And those who are young girls with PCOD, usually mother used to ask few questions which we can't able to answer. The first question is, does she get completely cured?
Metformin,
It's very difficult to answer in yes or no.
PCO can't be. Only issue is that all our young girls nowadays are going to cosmetologists. They're not coming to gynecologists. That is the main problem. And
Yeah.
the cosmetologists are doing gynecology. You'll find that when they come from, see, we are so scared about a cross-functional treatment. I'm very scared about writing a drug which pertains to cosmetology. They're all writing DCIs, MCIs, metformin. They are doing their ovulation induction. I'm quite surprised. The whole of the PCOS has been taken over by the dermatology team. So, because probably they are better communicators than us. Somewhere we are lacking. So I want you to start.
For irregular cycles in young girls, shall we go with OC?
Yeah, you can give. Again,
For how long?
you can give for 3 to 4 months safely.
After that, within 2 to 3 months, again irregular cycles, then how?
ये चलेगा, बाद में settle हो जाता है. You can add metformin for them.
Okay.
In case they've got glucose intolerance, you can add glucose. You can add metformin for them. You can give them OC pills. But that's the only way. I mean, settle up in some time. ठीक हो जाता है. After you reset their gonadostat, they become better. But there's a problem. There is a problem. You just can't. We don't have a concrete answer. But I do say that you read chapter 2. Chapter 2 has covered about the OC pills. In the guidelines, read that. It'll give you very good answer.
Those are school-going girls.
I know.
7th, 8th standard, and to give OCs, it's a bit difficult again.
People give OCs which are low dose OC pills are being given to them. But then what else can you do? What else can you do? We have to get their periods. It's a difficult answer to call to take.
Thank you, sir.
Yes.
So progesterones from day 5 to day 24 also we can give
No.
if the patient is less than 18 years of age.
You see, I think I'll limit myself to fertility. I won't go to anything else. Otherwise, it'll be Pandora's box, and there is no recommendations anywhere. But let's talk about fertility.
Sir, can we add along with letrozole? Can we give metformin?
Yeah, we can add, but there are no guidelines.
So what is the
I've gone through the
basic
guidelines.
difference in the management?
I've gone through the guidelines. They say in the guidelines, clomiphene plus metformin they are talking about. But letrozole and clomiphene, letrozole and metformin they are not talking about. Clomiphene, metformin they are talking about. But I'm giving.
Okay.
I'm giving. They got different rules. I'm combining letrozole and metformin.
Metformin.
Yes.
Okay, sir. Thank you, sir. Yeah.
So what is the basic?
Yeah, there are drugs available with combination of clomiphene and metformin. Someone is trying to make them. Letrozole and metformin, they are not recommended as per the ASHRAE guidelines. I couldn't find them anywhere. Yes.
Hello, good morning, sir.
Hi, good morning, Neena.
Sir, I want to ask when the AMH is very high. In the case of ART, what should I do and to stimulate ovaries? Sometimes they are not stimulated by oral drugs. And then the high gonadotropin we have to give.
Very simple.
Any other thing you
I'll
can?
tell you. Very simple answer. Very simple answer here is that we do get ladies who have got AMH. See, whenever the AMH becomes more than 3.5, my radars they settle. And when they cross 6, there's high chance of her having a problem. Now, two things occur here. One problem is of the ovarian hyperstimulation. Other is the expenditure. When the AMH goes high, the expenditure on the cycle will increase. Number 2. So how do we start such people? I think we start metformin 1 month prior, and never here we go on a chronic low dose protocol. What I do is that I start with 75 units of FSH. I don't go to 225 or 300. Some people go to 37.5 also, but I start. Start with 75, give 75 for 1 week or 8 to 9 days, then make it 150. That's the way you go. A cycle may go to 18, 90 days or 20 days even. That's okay. But don't try to push in 225 or 300. Then you'll have uncontrolled ovarian response. Keep giving for 10, 12 days 14 days, 15 days, and suddenly you'll find follicles that start coming. This is how they respond late, but they respond well, and they respond in a controlled way. Continue with metformin. So trick here is that you continue with the metformin. Continue with your hormonal stimulation. Don't carry out transfer in such cases. Number one, do plan for FSA. And all these candidates should be actually undergoing an NTAC cycle. Don't do a long protocol. Once you do a long protocol with decapeptyl or lupride, then the dosage will as such increase of FSH. So do get their withdrawal, get their period somehow either naturally or by withdrawal, and then you give them an AP protocol, antagonist protocol, and then continue for 10, 15 days, 18 days, 90 days, no problem. You find on 17th day, she will start responding. But don't get tempted by increasing that dose quickly to 150 or 225. And after we have done the cycle, the moment you've done the pickup, continue with NTAC for 2-3 days. Plus you add letrozole. So 2.5 milligram letrozole twice or thrice a day, give it to the patient. And then go in for a FET. This will ensure that she never gets any ovarian hyperstimulation. Very, very simple protocol. At least I have never got any, I've never seen an OHSS in past 3-4 years. Once I shifted to letrozole, OHSS has disappeared totally.
Thank you, sir.
That
And
is the letrozole
how-
dose first pickup for how many days?
I give it for 6 to 7 days.
Okay.
Safely, 6-7 days. See, in case you have letrozole with you, no, you don't need anything.
Okay.
Just do the pickup and send the patient home with letrozole. At
Sir,
least
So letrozole from which day of stimulation, sir?
no, after the pickup. After the pickup, no, the day of
After the pickup.
You do the pickup and give a letrozole and send her home. You'll find that she'll become completely luteinized and she won't have any ovarian hyperstimulation.
And sir,
Zero.
letrozole 2.5 milligram twice a day or thrice a day?
TDS, give TDS.
Okay, 7 days. Thank you, sir. Thank you.
You'll
Sir.
never have any ovarian hyperstimulation there. Just forget about OHSS.
sir, is
And
there
the letrozole to be started immediately after pickup on the next day?
Same day. Jaise
Okay.
khana khaya, jaise, see, there are 2 drugs which is already getting. She's getting cabergoline. Cabergoline never actually does any magic in my patients. I've never seen it doing a magic. And I'm not very fond of cabergoline, but I do give it. You continue with cetrorelix or cetrotide, whatever you're giving. Give it for 2-3 days, cetrotide. But the drug of choice here is letrozole. 2.5 milligram TDS, expenditure is around ₹600-700 only. 600-700 rupees is enough for you, and there is no ovarian hyperstimulation.
Sir, is there any relations between the LH, FSH, and AMH, which we can decide to go for ART or ovulation induction?
There is no relation at all. Relation is only of AMH. In case you were in आपके class में थे, you were in which batch, Dr. Vaman?
C1.
C1, हाँ, C1 में नहीं किया ना हमने ये. So C3 we or C2 partly we cover that there is no relation of FSH and LH. No relation at all. Zero relation. AMH is important, and AMH we look at AMH values more than 3.5 or 4. We take it as their hyperrespondence. So that has got a value, but LH FSH has got no value at all. LH FSH E2 have got no value.
Some patients that are having AMH more than 10, 13, 16, should we go with the ovulation induction or directly with?
No, in such cases also give letrozole. I always feel that the drug of choice is letrozole. So give letrozole 2.5 milligram once a day or give it 5 milligram once a day. So letrozole has got around 4 or 5 protocols, and letrozole dose we can increase.
Yes.
We can increase. The step stair protocol is a lovely protocol with letrozole. It's a beautiful protocol. So don't go to IVF directly. As far as possible, try to give them very, very simple answer. The simple answer is letrozole for 5 days, sometimes 6-7 days, 10 days. So letrozole के साथ try कीजिए 2-3 महीना. नई बात बनता है, then you can go for IVF.
Thank you.
Sir, one thing I have seen with letrozole, the lining of endometrium with the high dose of letrozole, sometimes lining of endometrium is not good.
Yes, it may occur, but letrozole overall gives you a good lining as compared to clomiphene. But high dose probably may be causing, I don't have any such an observation, but not we have given very maximum we have gone is still 5 milligram per day. Sometimes we give steps here protocol also have given, but I have not noted. Probably we have not done so many cases. This is to note that. You may be right, Doctor.
Thank you.
Sir, in case of low lining, hello.
Anji.
Sir, in case of low endometrial lining, can we add the estradiol?
You can. You should be adding.
Sir, dose how much?
You add estradiol. We are talking about estradiol valuate, no, Alpana?
Yes, sir. Yes, sir.
So we add it when we are hitting the follicle size of 14 millimeter and endometrium less than 6 millimeter. You add.
Okay.
I don't know take any brand here, so you can.
Sir,
add,
so how much? 2
milligram,
mg?
2 milligram TDS.
2 milligram OD?
TDS.
TDS. For how many days, sir? Say it to be continued for 15 days?
फिर बंद नहीं होगी वो, चलती रहेगी.
अच्छा, चलती रहेगी.
एक बार endometrium में चला गया, फिर बंद नहीं होगी वो.
Okay, sir.
Till the time you want to give luteal phase support, it will carry on there. Don't stop.
Sir, can we use metformin in PCOS?
Yes, you can use metformin. Metformin, thin PCOs are bad PCOs, in fact. In case I ask me which PCO will I'll pick up for OPU, I'll prefer it obese PCO. Thin PCOs can really cause havoc. Thin PCO, thin, tall, fair PCOs are the ones we should be afraid of. They are very bad.
Sir, we used to give agonist trigger in PCOS. So after how long we can plan them for FET?
After what I do normally is that I am never in any hurry. FET karna hai, after you have given the pickup now, done the pickup this month, and she'll get her period within 4 or 5 days or 6-7 days. She'll get her period. So that period you leave. Next period you pick up.
Okay.
This is what I do. But there are multiple. I've sent you that article already in the Alumnus group. A beautiful article which compares starting immediately after the pickup or after 1 month. The debate is going on, and but there is no evidence per se which method is better. But I feel comfortable that we'll find some follicles are still lying there, some corpus luteum will be lying there. Then why should we be in a hurry? Wait for some more time. Let us settle down and then we go for it. That's what I do.
Meanwhile, we used to give OCs.
Yeah, no, nothing to be given. Nothing to be given. She'll get her periods. Let the cysts get dissolved themselves. As far as possible, don't give any woman any OCs.
So we have to wait till the cyst gets resolved.
Yeah. It'll take 1 month. 1 month.
Hello, sir. If the fatty liver is there in PCO, sometimes you are finding SGPT, SGOT is very high. What drug you are giving?
Nothing. I won't comment upon this because I don't have any experience of fatty liver. So they go to the gastroenterologist, take their opinion, and I won't like to give estrogens or any other hormones with a fatty liver. At least I have never encountered such a thing.
Sir,
I'll reserve my answer on this. No experience.
so how to stimulate phenotype 2 of PCO patients with hyperandrogenism?
Same way. Metformin to hai na.
So poor responders की तरह behave करते हैं usually.
करेंगे. They will do. So that's what they say. You add metformin and you add. See, you have to learn to add some antioxidants are important. Somebody raised a question about NACFIL and acetylcysteine. Somebody had put a question in the chat box. So I think hyponate contains NACFIL. So N-acetylcysteine is a good drug for it's a good antioxidant for PCO patients. So you could use, but always feel that vitamin D, chromium is important. Chromium and vitamin D you can add to these people as an antioxidant. Along with
what should be the starting dose for these patients for IUI?
Same. It's
75.
100 milligram of clomiphene and 2.5 milligram of letrozole. Starting dose. In case they fail, then make it 5 milligram of letrozole.
And so gonadotropin 75.
Always 75. Ideally is 37.5. 37.5 I normally start with
सर
70.
उससे रिस्पांस नहीं आता बहुत बारी.
टाइम लगेगा ना. That's what I'm trying to tell you. Wait, be patient. जल्दी मत कीजिए.
So gonadotropins
Only FSH 75.
Yeah, 75.
from second day or after letrozole from 6th day?
You're talking about IUI here?
Yeah, yes, sir.
Yeah. So initial 5 days you give letrozole. So day 2, 3, 4, 5, 6 you give letrozole, and sixth day onwards you start giving them HMG or FSH for IUI, whichever you're giving, and give them 75 units. Never give them 150 units.
So 75 units for 3 days.
3 days, but maybe
Okay,
more.
sir.
Then you can't stop. Once you stop,
Yeah.
once you started HMG or FSH, then you cannot disappear and not do it. Then you have to keep giving it for maybe 5 days or 6 days. But 3 days or 4 days is good enough. 75
Okay.
milligram a day.
Okay. So would you recommend to use HMG even in stamped moderate PCOS, or you will go for FSH cycle only?
We are using HMG also. We are using HMG, but the recommendations say that LH should not be given. I've given you the recommendations. I think. 5.8 or 9 that I've given to you, they say LH should not be added, and they've also said that we prefer FSH.
Yeah, that's.
So see, Dr. Nita, the aim of these recommendation discussion is that I don't go by what I am doing. Otherwise, I'll give a wrong answer, because there are many people who will be doing a better simulations than us. I'm giving the recommendation here that LH should not be added as per the recommendation. FSH is a preferred drug.
Is there
any different guidelines for managing unmarried PCOS in Lilantine and the obese one, except weight reduction? Except weight reduction.
Same guidelines. I'm going to send you the guidelines within half an hour or so. Read from them.
Okay.
Akriti, you send the guidelines to all. Iske baad post kar dena.
Good morning, sir. This is Dr. Gupta here.
Yes,
sir. Sir, I just want to ask a question. Why there is a very low chance, means there is a take-home baby from PCOS patient is very less, because this patient get epigenetic changes and they get aborted by 7 to 8 weeks. Though we go for a FETs and go for a 5AA blast quality or day 5 or day 6. Why is it happen, and what is it
simple for
them?
The simple concept is there that we have to control their hyperandrogenemia. See, it's a problem with the PCOS, and PCOS is known to get poor quality oocytes. It is known to have embryo implantation failure. It's known to have early pregnancy loss. There's a problem with the PCOS. So in case you're able to control their hyperandrogenemia and insulin resistance, then they do good. But normally we are in a hurry. That's what I'm saying, that we don't focus on their weight loss. Don't focus on their dietary control. We are in a hurry to do their cases. Don't do that. Make them lose weight. Get their BMI to around 27. Have lifestyle modifications. Make them exercise, and you'll find there's a dramatic change in their outcome. But what you brought out is a very pertinent thing. It happens, but that's what is expected in PCO. That's the way it happens in a PCO patient. And this is a part of para 5.1, which I showed you. Assessment of the PCO patient. It's a known thing.
But this is okay with the obese patient, but lean PCOS, it's weird, sir.
Hyperandrogenemia तो वहाँ पर भी है ना, Dr. Gupta. See, insulin resistance and hyperandrogenemia, clinical and a biochemical, they both are having. So we have to reduce their biochemical hyperandrogenemia. And how do we remove it? By giving them some sort of antioxidants, some sort of drugs, remove all the metabolic parameters derangement which they are having, and then you do it. But गलती हम लोग करते हैं ना, we're in a hurry to start the cases. अभी आपने बोला FET करेंगे तो आपको benefit मिलेगा इसमें. अगर किसी do an FET, wait for 2 months, give her.
Yes, sir. We always do FETs after 2 to 3 months. 90 days का bracket ही रहता है sir कि to improvise their metabolites. We don't do FET until unless the patient comes a BMI 27. It's a perfect. But still what happens sir, there are epigenetic जो है उसका embryos का जो भी है, I don't know how it is 5AA quality, expanded, very good blast, ICM is very good, even you're getting the very good heartbeats, but they don't continue after 8 weeks.
Then you can do one thing, you can give them LH suppression. आप LH suppression कीजिए, in case you're not doing it. आप कर रहे हैं from day 21 add LH. Oh sorry, add agonist.
Yes.
Suppress. There's
हाँ
one.
sir, डेपो देता हूँ sir.
You can give short acting देके देखिए. ऐसा तो नहीं, this is not my finding कि I don't find any, we get very good outcomes. But if from day 21,
sometimes in the PCOS there is PAIA factor, clotting is there in the placenta, so we should add aspirin and heparin in such a cases. I should
not recommended, not recommended.
Okay.
You can add, recommended nahi hai. These are all
Okay,
personal, not recommended. It's got fibrinolytic changes, I agree. But aspirin, to we are giving to large number of patients as a routine, but not for PCO specifically.
Suppose, sir, if it again and again there is habitual abortions, or then we should.
These are the problems. That's what I'm trying to tell you, that try to control PCO metabolic effects.
Okay.
Then you'll get a better outcome.
Thank you, sir.
And then Dr. Gupta का जो सवाल है, Dr. Gupta, try giving them agonist from day 21. Try it out and continue agonist till the day of transfer.
Yes, sir. We have tried also this. We have tried each and every parameters which is in there in the recommendation of essay and book, but still somehow I am not getting satisfied. Right now I've got a patient which I have transferred the 3 blast. Out of this she got a 2 twins also. She aborted there, and 1 embryo is still there. 𝐏𝐿 is there, but we are getting this thing. Let's see.
होता है, ये है, PCO में problem है. This is known problem. That's the reason we're talking about PCOs. So there are problems.
Yes. बहुत मतलब कि you name anything, we have done it.
Vitamin D दो खूब सारा.
Yes, everything has been screened out. Sir,
I don't know, you would have done everything. You would have done everything.
Sir, आपका स्टूडेंट हूँ.
तो विटामिन डी काम आते हैं.
Yes. दिया सर, ऑलरेडी चालू है. एरेचिटोल करके इंजेक्टेबल भी और एवरी 1 मंथ से रिपीट होता है. 60 तक उसका 1 वीक चालू है. इवन पेशेंट को अपना धूप में 45 मिनट चलना इम्पोर्टेंट है. सब एवरीथिंग एंटीऑक्सीडेंट में उसको डिफरेंट कलर्स ऑफ द वेजिटेबल्स इज कंपल्सरी एज अ मेडिसिन. Everything what you tell me, everything has been there, and we have got a good results. It's not like I have actually got a 6 FET positive out of 7 after joining your course. It was really fantastic. I have changed.
करना चाहिए मेरे को, ये तो रिकॉर्ड कर रखना चाहिए और दिखाना.
नहीं, really it has made a lot of difference after joining the course, and patient भी बहुत सारे खुश हैं. लेकिन the thing is that कि कहीं तो epigenetic है ना सर, ये आफ्टर आई थिंक फ्रीजिंग हो या फिर थॉइंग प्रोसेस हो, इट इफेक्ट्स सर, ऐसा मुझे लग रहा है.
होगा, I think time will give an answer.
ये सर, क्योंकि बहुत सारे सर सेंटर्स है ना FET साइकिल्स कर रहे हैं. नियर अबाउट 80 to 90 पेशेंट दे आर डूइंग साइकिल्स ऑफ FET. इफ आई कलेक्ट द कलेक्टिव डेटास ना, everyone is not getting the pregnancy take home baby not more than 30 to 40%. Take home baby
40% is good. वैसे बताऊं तो 40% is pretty good.
हाँ, वही मैं बोल रहा हूँ. तो why it is like that sir? मैं कहने का मतलब कि it shouldn't. If we are doing FETs and if we are planning after 20 या 2 months 3 months checking each and every parameters, changing the lifestyle and everything, it shouldn't be. That means it the freezing में और कुछ thawing का जो अपना प्रोटोकॉल है या फिर उसका जो भी कंटेंट्स है, I think we are changing some epigenetic there.
Maybe हो सकता है. I don't deny that. PCO is a problem. We don't have many answers in PCOS. So though this is not my, I have not noticed it. But I'm sure you must be right. We have our own experiences. But overall, it's known to affect the oocyte quality. It's known to affect implantation. It affects endometrium. It affects every cell of the body. We should be careful, and but in case you're getting 40% take-home baby rate, that is a good rate. That's all I can tell you.
But why only 40%, sir? I'm just asking if we are getting each and everything of R&D done, okay, where we are getting freeze-all, we are getting a zonal 3, when get RIPI, PSV, सब चीज एकदम perfect है, blood circulation है, सब कुछ है. Then why there has to be some this problem?
I think now you can put some GCS7 PRP which you have learned.
नहीं सर, वो भी दिया है, वो भी दिया है. नहीं sir, I have gone through all this thing, and we are going for with a bone marrow aspirated CD also in the endometrium and ovary for PCOS also.
Then I have no answer. Then I have no answer.
We are going to come with the data after 1 year, after taking the 50 to 100 patients. तभी हम कुछ बात कर पाएंगे. But इनिशियल फेज में मुझे यही लग रहा है कि सर फ्रीजिंग का जो प्रोटोकॉल है या फ्रीजिंग का जो भी मीडियाज है, गायकॉल जो भी है सर, क्राई प्रेसिडेंट वगैरह, दे आर मेकिंग सम epigenetic changes, sir.
Maybe. I think let the time take the call and time give the answer. That's it. I think lovely discussion.
Thank you, sir. Thank you.
I've left few questions unanswered, but I don't have any answers.
Cases, sir, in PCOS cases, is there any role of LH in E2 before stimulation and before FET?
Though they say that PCOS are known to have high levels of E2 and LH. मिलेगा आपको. Whenever you check it, you'll get high levels of E2 and LH both.
Before starting E2 for endometrial preparation, no need to check E2?
No, we don't normally do. It is not recommended also that we should be checking E2 and LH because they'll be hypersecreted. So what we normally do is that in case you notice in bad PCO patients, we are automatically down regulating them with leupride. We start from day 21 and then we continue. Half dose करके continue कर लेते हैं उसको. But routine, don't carry out E2LH in all the cases, and it is not recommended also.
Cystic remnants, do you consider?
But doing it won't harm. In case your patients can afford, you can do it also. It won't harm the patient at all. But this is against the policy. That's what I'm saying.
And the cystic remnant from previous cycles, do you?
नहीं करना. Then don't start the cycle.
Okay, sir.
When you have previous cyst more than 1 centimeter, I never do. Then it's not the right thing.
Okay.
Make the ovaries down regulated.
Thank you, sir.
I think I in the last question I have to go to the opening now. Yes.
Okay. So myoinositol, some companies are coming with 2 gram sachets also. So is it?
I've showed you 2 gram sachet दिखाया था मैंने आपको.
मतलब दे सकते हैं सर, safe, it is safe or?
Are you talking about APCOT, no? APCOT की बात कर.
Yes, sir. Yes.
मैंने फोटो दिखाया था. APCOT people are giving and I've used it. APCOT is 2 grams per day. Some gives 550 milligrams, some give 1 gram. So see, everyone wants to be different. Frankly, बताओ, no one knows what they are doing.
Sir, उसमें फिर DCI भी one of the combinations of myoinositol with DCI 2 gram and DCI also is a high in number, so that will be helpful or?
The ratio, APCOT doesn't have DCI. Does it have DCI?
No, some other combination, some other.
No. The DCI, the actual combination is 550 of myoinositol, I think 14 of DCI. This is the accepted combination which we have in the market.
Once a day.
Once a day. Okay. High amount of DCI can lead to poor oocyte quality. Remember, DCI is harmful. Some people are adding now 19:1 ratio of MI to DCI. They made 19:1 now from 14.
Sir, if we are giving this DCI myoinositol, we should stop after ovulation induction.
Yeah. In case you get the result positive, you start. Then you have to stop as per the recommendations. But I do continue the. I don't give in case I'm giving DCI MCI I will stop. But metformin I do continue till the time I get a heartbeat. Metformin I don't stop. But as per the guidelines, we can stop. We should stop. So I think we'll stop here. It's very late. It's 11:30 in the morning, and we had a long discussion starting from 9:30 onwards. So thank you so much for being with us, and we'll be sending you the things right away. We'll send you the resonance. We'll send you the ASHRI guidelines also. Read, and then we'll connect again next Sunday.
Okay.
Thank you so much, guys.
Thank you so much, sir. Thank you, sir.
Thank you, sir.
Any queries you
Thank
can
you,
put in
sir.
the
Thank
group.
you.
Okay, bye. 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 Have a
Thank
nice
you.
day.
Bye.
Good
Bye.
day.
Bye. Bye. Stay safe.